So let's move on so we can finish at 1 o'clock. This is my last presentation about channelopathies. Again, I will try to give you just discuss the issues that I think that are most important for your daily clinical practice. So what is channelopathy, also called ion channel disease? It's a genetically determined disease because of a mutation of a gene of the ion channels of the heart. So as you probably know, the myocyte has a contractile system, but has also several ion channels that regulates the entrance and exit of potassium and sodium, etc., that regulates the length of the contractility. Okay, so if you have a mutation in these ion channels, you have modification of the electrocardiograms. You may have ventricular arrhythmias because of a normal electrical function of the heart, but from a structural point of view, so from a contractile point of view, the heart is completely normal. So you may perform as many echoes as you want, but you won't find any abnormality. The number of ion channels in the heart is very high, and having any mutation with gain or loss of function on each of these channels can give rise to a different phenotype. Okay, so today there are 5 different phenotypes of channelopathies that we know: the long QT syndrome, the short QT syndrome, the Brugada syndrome, the catecholaminergic polymorphic ventricular tachycardia, and the malignant early repolarization, which is the newest and least well-defined channelopathy. But of course today, for the sake of time and clarity, I will focus only on the 2 most common, the long QT syndrome and Brugada syndrome. Catecholaminergic polymorphic VT has already been discussed by Stefano earlier today. So, first of all, long QT syndrome. How should we measure the QT, which is one of the most difficult tasks for a sports cardiologist, a sports physician? So if we have a U wave, you see, this is the QRS, the T wave, and this small wave at the end of the T wave is called a U wave. Of course, if the U wave is separated from the T wave, there is no problem. But if they are merged, it may be difficult to measure the QT. In this case, you have to teach the tangent to the T wave and intercept the tangent to the baseline, and then so you can measure the QT. So this is the first practical thing that I wanted to tell you. And also another important thing is that you need to measure the QT in different leads, typically lead 2 and lead V5, and consider the longest QT. Look at this example of a patient with long QT syndrome. If we measure the QT in lead V3 with the method that I teach you, the QTC interval will be normal, 440 milliseconds. But if we take a look at lead 2, then we will see a markedly prolonged QT of 570 milliseconds. So again, in case of doubt, but in every patient, at least you need to take a look at lead 2 and lead V5, okay? Having said that, how long is a long QT? These are the same consideration for cavity size applies for QT. There is an overlap between gene carriers and normal individuals. There is a gray area roughly between 450 and 480 milliseconds in which the QT can be defined borderline. But a QT longer than 400, corrected QT, longer than 480 milliseconds is considered abnormal. And also a 470 millisecond can be considered as a cutoff for males, which has a which tends to have a shorter QT. But if you have to remember just 2 numbers, just remember 480, which is clearly abnormal. From 450 to 480, it is borderline. If you find a long QT in a patient, in an athlete, in a normal subject, the first thing you have to do is not to think about gene mutation, but is to exclude secondary causes. because there are many exogenous acquired causes that can prolong the QT. First of all is ion channel imbalance in the blood, so hypokalemia, hypomagnesium, hypocalcemia can all prolong the QT interval, but also the use of drugs, and among them some illicit performance-enhancing drugs can prolong the QT. So first of all, at least you need to perform some blood examination and to ask the patient for the use of drugs before thinking about a genetically determined long QT syndrome. Then, if you exclude these cases, then you have to make a diagnosis. How do I make a diagnosis of long QT? If you have a prolonged QT on different electrocardiograms, which is longer than 480, this is enough to talk about long QT. But if you have a borderline prolongation, then you need to consider other factors. And in this regard, there is this score that was developed by Peter Schwartz, which is probably the person which is the most known expert about long QT in the world. And as you can see, this is a score system, and when you have a borderline QT prolongation, you need to consider other features, for example, other HCG abnormalities, if there is a family history, if there are symptoms, etc. But this table may help you in borderline cases. Honestly, in the majority of cases, there is a test that tells the truth, which is the genetic testing. Genetic testing at variance with the arrhythmogenic cardiomyopathy that we talked about before is quite good for long QT syndrome because more than 80% of mutations for long QT have been recognized. So the sensitivity of the exam, the genetic testing, is pretty high and may be very useful in borderline cases or in familiar cases. And also, genetic testing has prognostic and therapeutic implication because according to the different gene that is affected, the modality of arrhythmia changes. For example, patient with a long QT1, which is the most common variant of long QT, which is caused by a loss of function in the potassium channel, usually develop arrhythmias during exercise, in particular swimming. On the other hand, long QT3, which is a rare variant of the disease and is caused by a mutation in the sodium channels, usually the patient usually developed arrhythmias during rest. So this is an important information. And also for risk stratification, to decide whether your patient needs an ICD or not, the defibrillator, you need to consider also the gene mutation, because some gene mutations are at a higher risk than others. And another important thing is that, again, the gender, which is another genetic, factor, because our X or Y chromosome is genetically determined, is another important determinant of the risk of a sudden death in QT syndrome. About Brugada syndrome, which is another, well, long QT syndrome is pretty easy because you just have to measure the QT, okay, which cannot be very easy, but you have the genetic testing, etc. So it's not that difficult. Brugada syndrome is a much more, in my opinion, tricky ion channel disease. What is that? It's a genetically determined disease. Everybody says it's a genetically determined disease of the sodium channel. The truth is, only in the 20 to 30% of cases of Brugada syndrome you can identify a mutation on the sodium channel. So the genetic basis of the disease are largely unknown. It shows a male predominance, and people who died suddenly for Brugada syndrome are usually male in the age of between the 40 or 15-year-olds, so they're middle-aged men. The HG, the electrocardiogram, is characterized by this ST segment elevation, and we will take a look in deep details later. And also, there are arrhythmic triggers that usually trigger sudden death in Brugada syndrome. So usually they die during sleep, so when there is an increased vagal tone, or when they have fever, or they are exposed to certain drugs, all factors that can increase the severity of so they can add to the genetic mutation to increase the degree of sodium channel dysfunction. Structure normal art. And out of curiosity, I can tell you that there is the majority of people, in the eastern countries, in the Middle East, in the Far East, like in the Philippines, etc., there is a high prevalence of Brugada syndrome. And this Brugada syndrome has been traditionally described as this monster called Bangungot, I think, which kills you while you sleep. So there is this tradition of this monster that suffocates you while you sleep, because these patients were suffering from agonal breathing during sleeping. So they thought that it was a monster that was strangulating you while you were sleeping. So this is quite an interesting thing. So the Brugada patient with Brugada syndrome may show a different electrocardiographic pattern. The first one is the diagnostic cover-type Brugada electrocardiogram, which is defined as a J-point elevation of at least 2 millimeters with a downsloping ST segment and a negative T wave. This is the only diagnostic electrocardiogram. But also they may show an ST segment elevation with positive T wave and much or less ST segment elevation. Those are the type 2 or 3 or Saddleback electrocardiograms, which are easily can be found also in the normal population. They can be easily confused with incomplete right boundary branch block. So those are not diagnostic. So you have to consider that this is a type 2 Brugada electrocardiogram. You see there is an ST segment elevation here, very clear, with a positive T wave. But this is a type 2, which is suggestive but non-diagnostic. On the other hand, this is the diagnostic Brugada type 1 electrocardiogram, which everybody of you now can recognize because it's very clear. Why do I have, for example, I have the gene mutation, Stefano has the gene mutation as well. Why do I show a type 1 Brugada ECG and he shows a type 2 or 3? Because the degree of phenotypic manifestation of disease is the sum of the severity of the gene defect plus the power of modulators. So if I have a mild gene defect, I can show only, for example, a type 2 electrocardiogram. But if I had fever, my type 2 can translate into type 1. But if, for example, Stefano has a strongest gene defect, he can show a baseline type 1 electrocardiogram. And as you can imagine, Stefano, poor Stefano, unfortunately, he has the Brugada type 1. And in this case, it means that his genetic defect is stronger than mine. It does not need additional modulators to disclose a type 1 ECG. Is it clear? Of course, if then I add additional triggers, for example, sleeping, from a baseline type 1, I can go to a ventricular fibrillation, because the degree of the genetic function becomes so high to give rise to life-threatening ventricular arrhythmias, okay? And of course, it is, as a consequence, Brugada patients with a baseline type 2 and 3 ECG are at low risk of sudden death, compared to those who showed a baseline type 1 electrocardiogram, which means that they have a strongest genetically defect. And of course, those with a type 1 ECG and arrhythmic symptoms like arrhythmic syncope or palpitation, etc., are the ones at highest risk of dying suddenly, of course. I think it's quite clear. The problem is, and let's come to the practical point of my presentation for you, is that the type 1 may hide itself. So it cannot be, you have to use some tricks to see if the patient really does not show a spontaneous type 1 ECG pattern. The first trick is to repeat if you find a type 2 electrocardiogram. Let's say you see a patient with this electrocardiogram, an athlete, okay? What do? The first thing is to ask him to come back on another day and repeat the electrocardiogram, because there is a spontaneous variation in the electrocardiographic patterns that you can observe in the patient. So if you perform different electrocardiograms in Brugada patient, you are likely to see variation in the electrocardiographic patterns. So some are diagnostic, some are not. So repeat ECG is very important. Or another thing that you can do is to prescribe a 24 hours Holter monitoring, which has to be 12 leads, and you have to position the leads in a certain way, but I will not go in deep details. But apart from that, in 24 hours, including sleeping, you may see the appearance of a type 1 ECG in a patient, in an athlete who was not a type 1 ECG on baseline. Another important thing is to perform the modified precordial leads. Why? Because the Brugada syndrome is a disease of the right ventricular outflow tract, the same part of the heart that gives rise to the arrhythmias that we saw yesterday. The right ventricular outflow tract is very nasty. It gives rise to many diseases. The position of the right ventricular outflow tract in the chest is not the same for everybody. So some have a higher right ventricular outflow tract and some lower. So if you want to explore it with the electrocardiogram, you need to position you need to perform 3 electrocardiograms. In the first one, you position the lead V1, V2 in the standard position, 4th intercostal space. Then you move to the 3rd. Then you move to the 2nd. And maybe you can see a Brugada type 1 ECG pattern only with higher precordial leads. Okay? So if you perform an Holter monitoring, and you have 12 leads, you use the 6 precordial leads to put it on the 4th, the 3rd, and the 2nd precordial spaces. So during the 24 hours, you can see if in some of these intercostal spaces, you can see a Brugada type 1 pattern. So you need to do these tricks. And second, now this is a case that observed in my practice. This is, for example, an electrocardiogram obtained on the standard lead position, which shows an ST segment elevation with a positive T wave, which is suspect but is not diagnostic. Just by moving the electrodes one space above, you can see that a typical Brugada ECG appears. Okay, so I don't know if you knew it. Another thing that Stefano told you about is the vagal maneuvers. Okay, and the simplest vagal maneuvers is the recovery during exercise testing. We see again here a patient with ST segment elevation but not negative T wave. At peak of exercise, an incomplete right bundle branch block appears, but there is nothing important. And during recovery, as you can see, you see a very prominent Brugada ECG. So another thing that you have to do in case of a borderline electrocardiogram is to perform a stress test. So repeat ECG or Holter monitoring, higher intercostal space leads, and stress test, everything is negative. The athletes has only a type 2 or 3 non-diagnostic Brugada ECG. Should I perform a sodium channel blocker test? So should I administer a drug that blocks further the sodium channels of the heart to see if a type 2 electrocardiogram becomes a type 1? The fact is, what we think is that no, you should not unless the athlete is symptomatic or there is a family history for Brugada syndrome. Because those patients with a type 1, type 2, 3 baseline electrocardiogram, no symptoms, have a very low risk of sudden death. And if you perform a sodium channel blocker test, you probably do not identify those at higher risk. You probably label many people with a disease that has no clinical relevance. So the consensus today is not to perform provocative tests for Brugada syndrome in athletes with no non-diagnostic electrocardiograms and no symptom or family history. The genetic analysis, as I told you, is not very sensitive, so it doesn't help you very much. Therapy for long QT syndrome, all patients should be treated with beta blockers. The most common used are propranolol and nadolol because there are the most scientific evidence around it. And if they are a high-risk patient, they should also receive an ICD. And if they have refractory arrhythmias, then there is a treatment that's called sympathetic denervation. So they cut the stellate ganglion in the neck, so as to reduce the sympathetic drive to the heart. For Brugada syndrome, low-risk patients, unfortunately, we don't have anything apart from general measure. So take paracetamol if the temperature rises above 38 degrees. Do not take certain drugs, but it's a very difficult task to evaluate these patients, because what you have to tell them is that the only therapy I can offer you is an ICD, but if you are asymptomatic, I cannot tell you whether this ICD will never be useful to you. So it's difficult. But I need to tell you, and we haven't talked about it so far, that there is another important option to treat particularly this kind of diseases that have a structurally normal heart and only a risk of arrhythmias, which is the subcutaneous defibrillator. So a traditional defibrillator has a lead that you have to put inside the vein and put inside the heart. This lead can break, can have infection, and this is not very good for young people because the rate of complication during lifetime is very high. Another opportunity is to put a defibrillator which is completely out of the heart. So you have the device which is put in the lateral position, and then a wire that is inserted under the skin over the sternal bone. This defibrillator cannot deliver pacing for bradycardias. It can only deliver shocks, but it is a life-saving device. It can be very good for young people that wants to exercise. Okay. Last slide. Sports eligibility. No defibrillator. Long QT syndrome. Sports activity is discouraged because of the risk of exercise-induced arrhythmias. For Brugada syndrome, there is a debate in the sense that Brugada syndrome arrhythmias usually occur during rest. Some say that the increased vagal tone correlated to athletic remodeling may, in theory, increase the risk of arrhythmias during rest or after exercise, but nobody has never described a case like this so far. So also the Italian guidelines today says that maybe Brugada patient with no arrhythmias and no family history of sudden deaths, etc., they may be allowed to participate in sport activities, but this is debated. If you have the defibrillator, patients with the defibrillator are protected from sudden death. You don't have the risk of disease progression because you have a structurally normal heart. So there are somebody, in particularly in the United States, that says that these athletes should be allowed to participate because they have demonstrated that the efficacy of the ICD in an athlete is the same in a sedentary individual, particularly if the defibrillator is a subcutaneous defibrillator that has less risk of rupture of the catheter during exercise. So in sports eligibility in these channelopathies is less strict than in structural heart disease. Just to conclude with the take-home messages for you, QTc duration above 480 is clearly abnormal. Between 450, 460 and 480 you have to consider other ECG features. You need to take a look at the SVAS score. Always exclude secondary causes. Genetic testing is very useful. All patients should receive beta blockers, and sport activity is not recommended unless there is an ICD. For Brugada syndrome, the type 1 is the only diagnostic. If you find a type 2 and 3, you must try hard and reveal a type 1 with a higher precordial leads and Holter, etc. But if there is no evidence of type 1 and the athlete is asymptomatic with no family history of sudden death, you should stop. Okay? Genetic testing is not useful. Stratification is very difficult, and the only therapy to prevent sudden death is ICD implantation. Eligibility to competitive sport activity is debated. Okay, thank you very much. It was my last slide. So.